Talking HealthTech was front and centre at Australia's biggest healthcare event this year, Digital Health Festival 2025. We were joined by over 8,000 other attendees, 400 speakers, 200 exhibitors, and over 150 startups for networking, announcements, and sessions across 10 conference theatres. During the show over the 2 days, I recorded a bunch of interviews with our THT Plus partners at their exhibition booths and up on stages to create some feature episodes of this podcast that you can find in this feed. As well as that, we decked out our customary pop-up studio on the expo floor, and I spoke with a number of speakers from the event and exhibitors who are making some big announcements from here in Australia and across the world. You'll find a handful of those shorter conversations I had during Digital Health Festival in this episode coming up, but make sure you jump into our YouTube channel as well, because there's a special DHF 25 playlist where you can catch all the other discussions as well. Collaboration starts with the conversation team HealthTech. Let's make it happen.
I'm Alan Pritchard. I'm the IT Director at Austin Health, which is a tertiary and quaternary public health service in the north of Melbourne.
Amazing. Alan, I just realised that after 520-something episodes of Talking HealthTech, I've got a diminishing list, but it's still an existing list of people that should have been on the podcast a long time ago, but it just, for whatever reason, it hasn't happened yet. So I'm super grateful that you've been able to have a chance to come over and have a chat here at Digital Health Festival. I've seen a lot around what Austin Health is doing in digital and technology over the years. I can hazard a guess at what brings you to Digital Health Festival, but what brings you to the event today?
So I come here to try and get in touch with what the industry is doing and where it's heading in general. I come here for the networking. It's a great event to catch up with all sorts of people. I come to try and learn about what we should be thinking about next within the health sector, although I also use other industries a lot for my guiding star, I suppose, when it comes to technology.
Yeah. That's super interesting. Well, tell me more about the using other industries.
Well, I don't think we do a great job with technology in health in general. There's good reasons why that, if you look back over the last 30 years, but we've got pretty broken systems. Most of our apps aren't great if you compare them to consumer grade or even the sorts of things that other industries, banking and finance, use. We're very slow adopters of almost every innovation at any scale, at least, and in any sort of enterprise and manner. But on the other hand, we have pockets of people doing cool stuff with little apps all over the place, which I think is great from a exploratory perspective, but it's not good from a patient experience and security and as I said, how we manage our estate of enterprise applications.
From my external observation, I understand Victoria, and specifically, I guess Austin Health and the region you're in, approach technology and EMRs differently to other states and how they might approach it. Talk to me about that approach towards the technology that you use within the health system.
Yeah, so Victoria, for historical reasons, has not had a centralised EMR delivery capability, such as they have in New South Wales and Queensland. I don't think that's necessarily a bad thing. Every health service gets to choose the tools and technologies that are right for its own clinical environment and its own workflows. Possibly there's a little bit of too much local customization goes on, but in general, I think everybody has tools that are fit for their own local environment. The disadvantage is there's less sharing of patient information across Health Service A to Health Service B, which obviously is enabled in New South Wales and Queensland. The advantage is I think we can innovate better and faster in Victoria than other places. The advantage is we can innovate locally in our own health services. And I think some of the disadvantages of all having different systems are starting to go away with the Health Information Exchange, CareSync Exchange, so that now the Department of Health is rolling that out and we will be able to see patient information across health services. And also some of the work we're doing with the CRM, which are kind of that patient engagement level, or digital experience level across the state. I think between those two things, they'll start to pick up the slack of not having everybody on the same EMR.
Interesting. And talk to me about some of like what that looks like, some examples of some recent innovations, because we're talking a little bit, like we heard a lot about the potential of generative AI and emerging technologies here at this event and just generally within healthcare. What are some examples of some more recent adoptions of emerging technologies, I guess, within Austin Health?
So within Austin Health, I think let's go back 6 years, we were one of the first health services to go all in with Microsoft 365 and adopt that as a licensing model and an approach. That doesn't, and this is what I mean about, we're so far behind in health. That doesn't sound very innovative, but it actually quite was at the time. And it's enabled the organization to move forward with sort of reporting and dashboards and better collaboration tools, and adoption of low-code capability across the Power Platform suite. So again, small innovations, but all built off the decision to move to a more modern platform, I suppose.
Yeah. And you were up on a stage at some point here at DHA?
Yeah, I've done two things. I was on a panel talking about real-world application of AI at Austin Health, or in health, and I've just done a little presentation at the Microsoft stand about what we've done with Gen AI. So specifically on Gen AI, about a year ago, I sat with my team and said, I think we need to get our hands dirty with this and do something, because everybody a year ago at this conference was talking about you need to govern it, but I don't know how to govern something if I don't know what it does or how it works or anything. So we picked a few projects that we could do internally, and we found a coalition of willing and engaged clinicians, some of whom brought their own projects. And we've really just done this sort of smorgasbord of projects, just looking at how we can leverage the AI, LLM, vision-related models that are available through Microsoft Azure, using our data, and see if we can deliver any insights or what we can learn from it. And I think what we've learned is it's not that hard. There's some great tools available. We're all using the same half dozen foundational AI models across the whole world, effectively. Every organization is pointing back to some variant of GPT or Llama or Birch or something like that. Clearly, Gen AI does some things really, really well and some things really, really badly. And I think that's why you need to get in and do some experimentation, because you've got to learn why some things work well and why some things work badly. And then you've got to understand how you can change that approach to try and deliver some clinical value. So we've got a lot of exciting projects going on, and I'm hoping that maybe this year some of them will actually translate into use.
Yeah, I love that. I mean, I feel like that makes a lot of sense to me. How do you go about allowing that flexibility to try things and fail and iterate and all that? As we always talk about in healthcare, it's like we don't have room to fail, and there's patients' lives and all this kind of stuff. And it's difficult to invest, be it time, people, resources, whatever, in I guess R&D or working stuff out. What's your approach there?
First of all of these are research projects. There's nothing operational here, and so that there's no risk associated with this. How you carve out the time is a really interesting one. So first of all, if you've got engaged people in your IT team and you say, hey, who wants to come and do some work on Gen AI, there's quite a lot of them are going to leap at the opportunity and really want to do it. Some don't. They see it as a threat, or they're just too busy with day to day. But there's some really engaged people who've jumped at the opportunity. And then the other thing is we have started using the industry supplied AI tools for development activities. So the same developers that are doing this kind of slightly frontier work with our data and Azure AI services are using GitHub Copilot to do their coding, their documentation. So they're clawing back a few hours a week on the one side and getting rid of some really humdrum work. They're making code reviews more efficient, and as a result, improving the quality of their code. And they're pulling back some time to devote to the more fun stuff.
Yeah. Lastly, Alan, anything that you'd hope that, I mean, there's always an interesting mix of people here at Digital Health Festival. There are clinicians, a lot of the vendor community, and a lot of, I guess, people keen to make an impact. What do you think people are starting to walk away from this event? And how much do you think will be applied into the real world of healthcare?
I think there'll be a huge growth in AI scribes, because that's technically a simple, well, actually I shouldn't say that. The scribing side of it is technically straightforward. The integration in the workflow is slightly less simple, but I think that there'll be a big adoption of AI scribing technology. Beyond that, I expect not a great deal will change. I mean, we evolve very slowly in this industry. I was just saying to somebody from Microsoft, I'm super proud of the little projects we've done. And when we got some actual results about how accurate Gen AI is to do a task, I was so excited. And then I read an article about the shipping industry that's using AI to make sure that container ships arrive at the port at exactly the time to be unloaded, and saving $250 million a year in fuel costs. And it's like, yeah, okay.
Catherine de Fontenay, Commissioner at the Productivity Commission.
Thanks, Catherine. It's great to see you here at Digital Health Festival. I feel like we kind of bump into each other at all the different things around and about. What brings you to Digital Health Festival?
I'm speaking on a panel about what digital technologies can do in the prevention space.
Excellent. When I've seen you up on stage in the past and in our conversations, I know the Productivity Commission has increasingly been more involved in the discussion around healthcare technology when I probably hadn't seen that in the past. Explain to me why that's the case.
Oh, excellent question. We've decided to stand up a permanent research team in health because it's such an important space. It's a space where it was hard to measure the productivity of what was happening in health, so we didn't know if we were doing a good job. If we measure productivity in terms of quality of life and life expectancy, then we want to know if we're doing a good job. And we wanted to know what the potential was for things to go better. So we did a paper last year on measuring productivity in healthcare and found that actually, whereas productivity in the regular market economy is pretty anemic, we were going gangbusters in health. We were delivering productivity growth of about 3% a year. That sounds small, but that's pretty amazing.
Okay, yeah. What does that mean, productivity growth? Like, what's the measure to say, hey, we're more productive?
So what we did is we took the data on what we spend on people with specific conditions. We could do this for about a third of all health conditions. So cardiovascular disease, most types of cancer, and blood diseases and endocrine diseases. And then we looked at what happened to people's life expectancy and what happened to their quality of life with the disease. And what we found was that from about 2011 to 2018, life expectancy had improved amazingly. Quality of life, while you have the disease, not as much, so there's still lots of potential to improve there.
When you say that, Catherine, I think about, look, that's, it's almost like, oh, cool, like here in healthcare, where we're, you know, a step above the rest of the economy and all that. But then I think back and I'm like, the amount of conversations we have in the ecosystem about how we need to do more with less and we need to be doing better. And we talk about burnout. We talk about all the issues in healthcare, the cost and the inequities. And so that doesn't marry up what you're saying. So why is there that separate? Should we be trying to be more productive if it's not even doing this, if you know what I mean?
Look, we should absolutely be trying to be productive, but the productivity gains we've had have been in terms of better quality outcomes from our health system. What we haven't addressed is the cost of our health system, and that we really have to address.
Yeah.
So we can't keep spending more and more of our GDP on health. Meanwhile, we're facing an aging population, a population with more complex conditions. We have to do something to deliver their care more efficiently. And that's why I'm super excited about digital technologies. And we also wrote a paper on digital technology in healthcare, because we think that for the first time in ages, we have some technologies on the table that could really be game changers in terms of delivering not just better healthcare outcomes, but much cheaper healthcare outcomes. So if we can send people home from hospital sooner, if we can save a lot of healthcare workers' time with AI, then we're going to be able to help with burnout. We're going to be able to help with ramping, with all of those backlog problems that we're all stressed about.
What I like too is that, we've got you here sharing these insights, Catherine, at Digital Health Festival, which is such a bringing together of the ecosystem. I know you've been very active in sharing some of this with different parts of healthcare. I think about, we've got the startups down in Startup Alley there, and there's clinicians out on the floor too. Sometimes it might feel a little bit like nebulous of like, well, the Productivity Commission is over here, or here's like some insights. Is that how we should engage with the productivity? Like, we wait for stuff to come out, or like what should people do now that we've got this information? What should we do about it, type thing? Yeah.
Well, I think that this health community should tell us what they think the problems are and what needs to be done to fix it, because then we'll produce better research. But now that we have this information, I think that we need to move a little faster, pushing digital technology out into the sector. For instance, we know that remote patient monitoring, sort of sending a patient home early with equipment to monitor their blood pressure, their heart rate, their insulin, can hugely reduce the risk of readmission to hospital. We know that using AI like scribe tools and just better patient management can save about a third of healthcare worker time. Imagine giving every healthcare worker back 11 hours of their week. That seems pretty damn appealing.
Yeah, sure.
And, in a world where they are tired and overworked and burned out, don't we want to give them 11 hours a week?
Yeah. Lastly, Catherine, you mentioned the scribes, the emerging tools, the innovation. We, on one hand, on paper, that sounds great, but then you bring in all these other complexities around safety, security, uncertainty, and risk, and everything in emerging technologies. Where do you see the role of artificial intelligence, emerging technologies, or the risk versus reward piece come in?
Yeah, look, I think the evidence so far suggests that the rewards really outweigh the risks. And I think sometimes we measure the risks against an artificial benchmark. So when we look at a scribe tool, we want that scribe tool to have 0 errors. We don't say, what is the error rate compared to a human writing this down in unintelligible doctor handwriting? What's the risk that the next person can't read that information? What's the risk of a patient going to a consultation, being told they have cancer, and then not hearing anything from the next 45 minutes of their consultation? So what we want to do is we want to balance the risks of AI, and we want to keep checking how it's performing, and that's a good role for the TGA and other regulators. But we do want to balance that against the risks of the alternative.
So my name's Shannon Nott. I'm the Chief Medical Officer for the Royal Flying Doctors Service South Eastern Section, so overseeing care across New South Wales and ACT. I also have that dual responsibility of being the Executive General Manager of Health and Clinical Services. So it's not just looking over the medical services we provide, but much broader than that. By way of background, though, I'm a rural generalist doctor, so I provide a wide range of clinical services, so things from anaesthetics to emergency care to remote primary care in rural and remote areas. And prior to being with RFDS, I had the pleasure of working with New South Wales Health as their clinical director of the Virtual Care Accelerator, so being able to provide, I suppose, and support the virtual care response to COVID-19, and then transitioning into a statewide role role as a medical advisor around virtual care strategy. So across in the RFDS environment now.
Yeah, look, I mean, and it's great to have you here at Digital Health Festival, and that makes a lot of sense in terms of the background. And I think about RFDS and I guess the communities that it serves, being those that are in areas that they couldn't otherwise access health services or to fly in to receive medical care. And when I think about the RFD, or when someone might think about the RFDS, think about the planes or the infrastructure, and that's like the focus. But it's interesting to see you at Digital Health Festival. Tell me a bit more about why you're here.
Yeah, look, I think naturally people think of it's usually due to the TV series about flying around in planes and the drama of all of that. But the reason why I'm here is that RFDS is intrinsically linked with technology, innovation, and looking at new ways of addressing some of our significant challenges for rural and remote healthcare. If you think about the whole premise of RFDS being born, the Reverend John Flynn, who was the founder of RFDS, actually sparked sort of enthusiasm following a tragic event where a stockman called Jimmy Darcy tragically passed away up in a remote part of the Kimberley. And it was following this sort of national attention where there were the disparities and geography and remoteness was front and centre for a lot of Australians. John Flynn was able to utilise that interest to be able to start getting our first planes up in the air and being able to support rural and remote areas. It wasn't long after that, though, that they realised that they were only as good as the people being able to call for help. So very reactive. And if you think about the early 1920s when RFDS started getting planes up in the sky, a lot of rural and remote areas had no forms of communication. They weren't on telegram wires. And so people might have had to ride a horse hours away. And so Flynn worked with a gentleman called Alfred Traeger, a German engineer, to develop the first pedal radio so that communities suddenly had a voice, a way of being able to call for help, but also seek medical advice in community. And that sort of trend and premise of being able to provide the finest care to the furthest corner is part of that RFDS mantra, that mantle of safety that we have for rural and remote communities.
Wow, that's fascinating. And I know that you were up on a stage here at Digital Health Festival too. Tell me a bit more about that, because I think you were kicking things off, right?
Yeah. I was the lucky or unlucky guy that gets to kick off the first session in the virtual stage here at DHF.
Yeah.
You're always a bit concerned about whether people get away from the coffee or turn up to the conference in time. But it was great to see so many people from different sectors filling out that sort of area. And I think it's a testament to the fact that there are so many people with different walks and talks of life. There are technical people, there are data people, there's government, not-for-profit, business, private, small enterprise, large, coming together. And I think it showed that everybody was really interested in how do we actually change that dial. My talk focused around this aspect of equity, and that if we don't, as a collective health sector, if we don't work together around designing models of care supported by digitisation, by technology that meet patient outcomes or patient need, then we've failed across the sector. If we can't support programs that support our most vulnerable communities and vulnerable patients, then we've failed in all of this. Yeah. The whole point of coming together across the sector is to be able to innovate for the benefit of patient care.
So I'm Karen Gallagher. I'm the General Manager of Strategy and Consumer Experience at Healthdirect. We are the national provider of trustworthy health information, and we connect people to care 24/7, and we're owned by all 9 governments of Australia. So in my role, the real focus I've been taking over the last year is to be looking at how we can understand more about consumers' needs and their behaviours, about why they're going to emergency, how can we support them to care for themselves and use our health information effectively to both make sure that they're as well as they can possibly be, but also to ease pressure on the system and make sure they get to appropriate care.
Yeah. No, look, it's great to connect, Karen. And I just thought as you were talking, it's almost like Healthdirect is like my Pokemon, because I'm catching them all at different... We can run with that one. That's cool. It's totally on brand. But important message that you've, because we've spoken with a number of people at different events from Healthdirect and some longer form episodes that people can go and check out on the feed. So it's great to be able to connect here at Digital Health Festival. And I understand you're speaking on a stage as well. Tell me a little bit more about what you're covering.
Yeah, so I'm speaking about looking after yourself, so self-care, and what we might be able to do to help people to follow our advice when we provide that. So when you think about the health system over the last couple of years, a lot has changed. A lot of new pathways have been added, virtual pathways, urgent care clinics. One of the pathways that is, I guess, not really recognised as a pathway is people looking after themselves. And on our helpline at the moment, about 16% of our callers are advised that it's okay to stay home and look after themselves. But what we're finding is that they don't always follow our advice. And so we wanted to look into why that is and why are people potentially going to emergency or to something other than what we recommend.
So they say, hey, you're fine, but then they go into ED or something regardless, right?
Yeah. And or they might go and see their GP, even though we've said you can stay home. And so we've been looking at understanding from consumers why. What's the why behind that behaviour? And then how might we support them to follow that advice? And so part of the reason for this is that when we look at the pressure on our system, we know that there's a lot of people going to emergency that maybe don't need to go to emergency. And we also know that we've got a workforce challenge.
Yes.
And so it doesn't matter how many new pathways we put in, if they're still reliant on the same workforce, we are still going to hit at the point where demand might outstrip supply.
Yeah.
So we really need to start looking at, well, how do we build that consumer confidence and their capacity and their skill set to look after themselves when we advise them that it's safe to do so?
Interesting. And so what would you, I think about from my own perspective there, where we have, if you're a patient or more often a carer, if they're engaging with Healthdirect, and you're like, well, and I imagine the interaction goes, well, if you're unsure, of course, you could go to the GP. There's always like an element of, oh, look, I'll go just to be safe. But like what I hear you saying too is that if we can address that uncertainty with an on par or an appropriate level of care through another modality that doesn't involve them clogging up the system, for want of a better term, or utilising the system for something that was not perhaps necessary, then I guess that benefits overall.
Yeah, that's right. And so we did some consumer research last year. We used a human-centered design research mode to talk to people, and we also talked to nurses as well. And we did some prototyping with consumers to look at what types of solutions might work for them. And one of the key findings, I think the word that it summarises for me is worry.
Yes.
So when we're talking about it's really common for a parent to have a child that has a fever, they're screaming in the middle of the night, they just genuinely don't know what to do. It might be their first child. Yeah. That sense of worry is huge. And so we found 3 key things that I think are really important. Firstly, the pandemic has really trained people to worry about symptoms that they previously didn't worry about. So when I grew up, we had an ad campaign that we all knew the words to, which was soldier on, let's soldier on.
Let's not give them brand recognition, but yes.
Yeah, exactly.
I'm well familiar with that song and now it's in my head, yes.
And now what we know is that you shouldn't go to school if you have a sniffle.
Yeah.
And you should stand 1.5 meters apart. And even today, there's the headphones that everyone's wearing in the silent theaters. And I heard someone say, but is that clean? Like, is that a good, we've trained people to be quite cautious about something that previously they might have had more confidence in. And so as a result of that, they're worrying and they're taking a wait and see approach before they might head to ED. But that wait and see, because they know that ED is going to be an 8-hour wait. They don't want to wait for 8 hours. They don't want to be tired when they wake up in the morning and maybe miss work. But the problem is that wait and see is only lasting as long as their confidence and skill lasts for them to look after those symptoms effectively. And sometimes those can be quite variable as well, So we do want them to call us. We'd like them to call us back.
Sure.
And then the final thing is that whether it's going to the GP or going to ED, what we found was that consumers are looking for reassurance after that. So they're still leaving going, okay, you've given me advice, but I'm still sick. I'm still worried. And so there's a real opportunity for us to think, well, it's not just a single interaction. These consumers leave and they feel alone and they're still worried. So how might we extend that moment of care and have some kind of check-in or interaction with them? And so some of the solutions that we designed together with the consumers were really trying to target those moments of that post-care reassurance, and also making the advice simpler and easier and more personalized to interact with using like a RAG AI model. So that it's just when you're tired and sick, you can get something that's not an 11-minute read.
Yeah.
You know?
Exactly.
Yeah.